Yeah. Good morning. Let us practice drawing the scapula today and therefore learn the anatomy around the scapula. So here is the glenoid cavity where the upper end of the humerus articulates. This is the supraglenoid and the infraglenoid tubercles. Then there is a bent finger-like projection which is called the coracoid process. It leads to a notch, which is the suprascapular notch, the superior border of the scapula, the medial border like this, and the lateral border. So scapula is a triangular bone and we are looking at it from the front. So here would be the head of the humerus. Here would be the greater tuberosity. Here would be the bicipital groove, and here will be the lesser tuberosity. Now, connecting the head of the scapula to the head of the humerus, first there is what is called as the cartilaginous projection, which is the glenoid labrum. Then there is this capsule. The capsule is attached to the margins of the glenoid, but it is attached to the anatomical neck of the humerus, but not on the medial side. Medial side, it is the lax part of the capsule, and this lax part allows abduction. So this is the capsule. It is strengthened by the superior, the middle, and the inferior glenohumeral ligaments. Arising from the supraglenoid tubercle within the capsule is the long head of the biceps, which is held into the bicipital groove by the transverse bicipital ligament. Below the transverse bicipital ligament, you will have the rest of the bicipital groove, on which is attached the lady between two majors. The pectoralis major on the lateral lip, the teres major on the medial lip, and the latissimus dorsi in between. So this is the teres major, this is the pectoralis major, and this is the latissimus dorsi winding around the lower border of teres major, getting attached in between the two lips. From the anterior surface of the scapula to the lesser tuberosity, we have made the subscapularis muscle. From behind the scapula, the spine of the scapula converts into the acromion process, which overlies the head of the humerus. From it arises the clavicle, the lateral 1/3 concave forward, and on the inferior border of the lateral 1/3 is a trapezoid line extending externally from the conoid tubercle. Now the coracoid process that we see from the next in the supraglenoid tubercle is the coracoid process. So this coracoid process gives rise to 3 ligaments and 3 muscles. The 3 ligaments are the coracoclavicular, the coracohumeral, and the coracoacromion. Coracoclavicular, coracoacromion, and coracohumeral. Visualize them going to the 3 bones: coracoclavicular, acromion, and humeral. The coracoclavicular ligament attaches the coracoid process to the lateral 1/3 of the clavicle, and it has got a trapezoid antero-external part, TRAE, anterior external part, and a conoid part which is attached to the conoid tubercle. Now this ligament holds the lateral 1/3 of the clavicle into the acromioclavicular articulation, and this must rupture if there is a dislocation of the acromioclavicular joint and the lateral 1/3 has moved up in relation to the acromion process. Now, the other importance of this attachment of the coracoclavicular ligament is that if the fracture is medial to its attachment, then the proximal fragment can move up as much as it likes. But if the fracture is lateral to the attachment of the coracoclavicular ligament, the attachment of the coracoclavicular ligament to the proximal part will prevent its upward displacement. So, after the coracoclavicular ligament, the coracoacromion ligament, which completes the arch above the head of the humerus, and the coracohumeral ligament. So the three ligaments completed. Now we'll place the three muscles. The three muscles are the long head of the biceps. The biceps has two heads, the short head and the long head. The long head of the biceps is originating from the supraglenoid tubercle and passing through the bicipital groove. The short head is originating from the coracoid process, in which we have just made. The second muscle is coracobrachialis, which we are making, which arises from the coracoid and attaches to the middle of the medial border of the humerus. The third is the pectoralis minor, which we are making, arises from the coracoid and gets attached to the ribs of the thoracic cage. So the three ligaments are coracoclavicular, coracoacromion, coracohumeral, and the three muscles are short head of biceps, coracobrachialis, and pectoralis minor. The short head of the biceps and the coracobrachialis go into the arm, and the pectoralis minor to the chest wall. So this fascia connects the inferior border of the medial 2/3 of clavicle to the pectoralis minor. It is called as the clavipectoral fascia. You can see that the lateral part is continuous with the conoid part of the coracoclavicular ligament, and this fascia is pierced by four structures: the cephalic vein, the lateral pectoral nerve, the lymphatics, and the thoracoacromion artery. So this finishes the anatomy around the coracoid process. You would find that from the lesser tuberosity, attached to the lesser tuberosity from the anterior surface of the scapula is a muscle which is called as the subscapularis muscle. So this is the in the lower part of the bicipital groove, you would find that there is the lady between two majors, is the pectoralis major. On the medial side, there is the teres major. And between them, there is a muscle which winds round the lower border of teres major, forming the posteaxillary folds. It winds round the teres major. This is the teres major. And this is winding round it, like this. And this is the latissimus dorsi. So pectoralis major, latissimus dorsi, teres major. So lady between two majors. Then after the teres major, there is the teres minor. Now this teres minor muscle will go behind the capsule and the head and get attached onto the greater tuberosity of the humerus. So the structures attached to the greater tuberosity of the humerus are sit structures: the supraspinatus, the infraspinatus, and teres minor. Supra, infra, spinatus, and teres minor. So the capsule, the lax part of the capsule you see is sandwiched between the subscapularis and the teres minor. It is a sandwich between this. From the infraglenoid tubercle, so here is the teres major. From the infraglenoid tubercle arises the long head of triceps, passes in front of the teres minor, behind the teres major and latissimus dorsi, and goes behind the humerus, goes behind the shaft of humerus. So this long head of triceps converts the spaces between these muscles into a quadrangular space. This is the quadrangular space, into a medial triangular space, and into a lateral triangular space. Boundaries: quadrangular space, upper boundary, lax part of capsule sandwiched between subscapularis and teres minor. Inferior boundary, teres major. Medial boundary, long head of triceps. Lateral boundary, surgical neck of humerus. So this is the boundary of the quadrangular space, and the axillary nerve and the posterior circumflex humeral artery passes from this quadrangular space and winds round the surgical neck of humerus. So it winds round the surgical neck of humerus. So this is the axillary nerve and posterior circumflex humeral artery. Nothing passes through the medial triangular space, but the circumflex scapular passes piercing the teres minor muscle. So this is the circumflex scapular artery. And the radial nerve passes through the lateral triangular space. So we make the radial nerve, and the artery which accompanies it is the profunda brachii artery. So radial nerve and profunda brachii artery passes from the lateral triangular space. All right. Now on the medial border is attached scapulae, the rhomboid minor and rhomboid major. And all these muscles are going to the spine. But from the medial border, from the medial border, winding round the chest and getting attached to the ribs is a muscle which is called as serratus anterior. Serratus anterior. And this muscle will actually pull the scapula forward like punching. So this is the protractor of the scapula. So this will produce protraction, and the serratus anterior is supplied by nerve to serratus anterior. So these are the structures attached to the medial border. Another thing about the levator scapulae, that it is coming from the spine, it elevates the scapula, lifts the scapula up, and if it is shortened or fibrotic, then that side of the scapula will be higher, and that is called as a high shoulder or springal deformity. So if this can be fibrous, this can be contracted, or it can become a bone. When it becomes a bone, it is called as omovertebral bar. Omo means scapula, vertebral means vertebra. It is also called as omovertebral bar. And if it happens on both sides, then the neck is short, both shoulders are risen up, and the syndrome is called as Klippel-Feil syndrome. Now we'll make the posterior part of the scapula. So here is the glenoid cavity, here is the supraglenoid tubercle, here is the suprascapular notch, here is the superior border, here is the medial border. You are looking to the scapula from behind. Now this posterior surface of the scapula is divided by a projection, a shelf-like projection, which is called as the spine of the scapula, and that goes up and becomes the acromion process. The inferior border of the spine of the scapula has a tuberosity here, which is called as the deltoid tuberosity. We will proceed to make the head, the greater tuberosity, and the shaft, and there is no lesser tuberosity and bicipital groove on the posterior surface. Here becomes the capsule, lax part of the capsule. Here we have made the teres minor attached to the lower part of the lesser tuberosity. Here is the infraspinatus, the SIT, and here is the supraspinatus coming and getting attached to the superior most part. So SIT. Then you have the teres major, which is going anterior to the, and this teres major is winded round by the latissimus dorsi. So long head of triceps coming from the infraglenoid tubercle anterior to teres minor, but posterior to teres major, forming the quadrangular space, the medial triangular and the lateral triangular space. And in this lateral triangular space emerges the radial nerve and the profunda brachii artery, and from the quadrangular space emerges the axillary nerve supplying the teres minor and the deltoid. So we will make the deltoid from the outer surface of the acromion process, coming and getting attached to the shaft of the humerus here. So this nerve, axillary nerve, supplies the teres minor and the deltoid and the skin over the deltoid in an area which is called as the regiment batch area. Axillary nerve is accompanied by the posterior circumflex humeral artery. Posterior circumflex humeral artery, axillary nerve, radial artery, profunda brachii artery. And the teres minor is pierced by an artery which we told you is circumflex scapular artery. Then we have placed the levator scapulae, the rhomboidus minor and rhomboidus major muscle. So we place the levator scapulae, the rhomboidus minor and rhomboidus major muscle. Now above, the acromion will articulate with the clavicle like this, and inserted into the clavicle, inserted into the posterior border of the clavicle, the upper border of the spine of scapula, the medial part of spine of scapula, the inferior border of the spine of scapula right up to the deltoid tuberosity is a muscle which is coming from the neck and the head, and this muscle is called as the trapezius muscle. So it's like this. So this is the boundary of the trapezius muscle, and it will go right up to here. So this is the trapezius muscle from the posterior border of the clavicle, the superior border of the spine of scapula, the medial border of the scapula, and inferior border up to the deltoid tuberosity. Then the deltoid muscle is taking origin from the anterior border of the clavicle, the acromion process, right up to the inferior border of the spine of scapula up to the deltoid. So this is the deltoid. So latissimus dorsi, deltoid and trapezius form a triangle. These are the first muscles that you encounter when you divide the skin. So this is the anatomy of the around the scapula. Now let us draw diagrams to explain as to which muscles will elevate, depress, externally rotate, derotate, protract and retract. So the scapular movements, as I told you, are elevation, the arrow pointing upwards, depression, downwards, protraction, as the scapula moves in this direction, retraction, exactly opposite of that, external rotation, that arrow going around that axis like this. Now that axis starts from the deltoid tubercle and goes up to the sternoclavicular joint. So on that axis, this is external rotation, and the glenoid will start pointing up, and the opposite of that is derotation. So elevation, depression, protraction, retraction, external rotation, derotation. So protraction first. You are seeing the scapula from above, and the serratus anterior arising from the medial border of the scapula and attached to the rib pulls the scapula forward over the chest wall, and this movement is protraction. The rhomboids and the medial fibers of the trapezius, which are attached like this, would retract the scapula. So after finishing this protraction and retraction, the elevation would be produced by the upper fibers of the trapezius and the levator scapulae. The depression would be produced by the lower fibers of the trapezius. The lower fibers of the trapezius, these ones, the latissimus dorsi and the pectoralis minor, which is arising from the coracoid and attached to the ribs. So all these muscles will pull the scapula downwards. Now you understand this, that if the acromioclavicular joint is depressed, then the elevation at the sternoclavicular joint will simply elevate the shoulder. It will not rotate. But if this acromioclavicular joint is elevated and it is rotating with the clavicle, then the whole scapula will rotate and the glenoid will start pointing upwards. So this will become the position. But that requires that this acromion process is fixed to the clavicle at the acromioclavicular joint. Then as the clavicle rotates in the sternoclavicular joint like this, the whole scapula will rotate with it, the glenoid will start pointing upwards, and there will be overhead abduction of the shoulder. So this is the elevation of the sternoclavicular joint. If combined with a flat acromioclavicular joint, it is simply elevation of the shoulder. But if combined with a fixed and externally rotated acromioclavicular joint, it will lead to rotation of the scapula, glenoid pointing upwards, and overhead abduction. Now notice and the muscles in this photograph. You see the trapezius arising from the medial third of the sphenonuchal line, the ligamentum nuchae, and from the spine of all thoracic vertebra right up to T12, and getting inserted on the posterior border of the lateral 1/3 of the clavicle, the medial border of the acromion, the superior border of the spine of the scapula. These are the upper fibers pulling the lateral part of the spine of scapula upward, and the lower fibers, the lower green arrow, pulling the medial part of the spine of scapula downwards, so that on the axis that you see, the red point, there is a rotation movement. Now this rotation of the scapula is helped by the serratus anterior, which is pulling the medial border of the medial lower border of the scapula forwards and upwards. So trapezius and serratus anterior is producing the external rotation. Now in this external rotation of the scapula, if the acromion remains adducted in relation to the clavicle, then there is simply lifting of the shoulder, which is the shrugging of the shoulder. But if the acromion is also rising up with the clavicle at the sternoclavicular joint, then this becomes scapular rotation. Next, notice that the lateral border of the trapezius, the medial border of the deltoid, and the superior border of the latissimus dorsi form a triangle. So after this, let us proceed to. On the left side, you see the levator scapulae, the rhomboidus minor and the rhomboidus major, coming from the cervical spine and attaching to the scapula. The levator scapulae elevates the scapula, and if it is fibrosed, then it prevents the descent of the scapula. That is called as the springal deformity of the shoulder. When it becomes bony, it is called as a omovertebral bar. Omo means scapula and vertebra means the vertebral column, and bar means the bone. Then if it happens on both the sides, then the syndrome is called as the Klippel-Feil syndrome. The rhomboidus minor and major would pull the scapula medially or retract the scapula, and the supraspinatus, infraspinatus, and teres minor are the 6 structures attached on the greater tuberosity.